السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. My name is Abdulellah, a third year medical student, and today we're going to have a lecture about the renal anatomy, which is a crash course. This is the second segment of the crash course. Don't miss the first segment done by my colleague, and see this one also. So before we start, this is my contact info, email and phone number. Please, whenever you have a question, don't hesitate to reach out. Second thing, this lecture is going to be more of an interactive. So if you could respond to the questions in the chat box. So the formula of this lecture is going to be more over showing you pictures and then a bit of questions. If you answer them, that's wonderful. If you can't answer them, don't worry, we're going to discuss the matter furthermore. So that's in general the workflow, let's say, of the lecture. So let's start. So we're gonna start with the basic anatomy. We're gonna move to the clinical application, and we're gonna discuss the cross-sectional images. So let's kick in with the basic anatomy. Now, this is a anterior view of an abdomen. We remove the anterior abdominal wall, and we can look for the area below the diaphragm. So this is the diaphragm. This is the aorta. This is the IVC, which is the inferior vena cava. And then we have to see here the two kidneys. Now, this is the right kidney, and this one's going to be the left kidney. So they're quite opposite sides because you're seeing the patient as let's say this cadaver or this image from the opposite side. So this is the right kidney. This is the left kidney. You can see that from each kidney, we have one ureter that descends, goes down all the way to the bladder and enters into the bladder. Now we're going to discuss the pathway later. Just orient yourself with the kidney, with the ureter. You have the bladder. You have here also the aorta, the abdominal aorta. It bifurcates, which is going to be spreading into two different parts or two different legs. We can see here some arteries are supplying the ureter. We can see also here we have a bit of muscle. We have the psoas major muscle, one of the important muscles in the posterior abdominal wall. We can see here that we have the rectum. Now we let's say we had a quick introduction about the anterior abdominal wall. Moving on, does anyone know what structure is this? Just type it in the chat. Yeah, that's the pelvic brim. Now, Dr. Vlad, I guess this lecture is for Dr. Vlad, mentioned a couple of structures that he wants you to know. So this structure is what? It's a foramen. It's the obturator foramen. Exactly, that's correct. Next is going to be this structure. This is not a bone. This is a carpet. Exactly, the pubic symphysis. Next is going to be this structure. Now we're not targeting the bone, the joint. So what joint can be found here? The sacroiliac joint, exactly. So this is the sacrum, and this is the ilium, the iliac, sorry. So that's the sacroiliac joint. So it's a joint between the sacrum and the iliac. So sacroiliac joint. Finally, it's going to be this bony process. What do we call it? Sacral spine, exactly. So the ischial spine. Next, let's kick into the basic anatomy and let's have an overview. So, as we can see here, that this is a male pelvis. How do we identify? From the internal organs, from the external male genitalia. Now, the question that appears here is that whenever we have anatomy, we need to know the overall image to identify structure and then go deep into it. So this is a lateral view of a male pelvis. Now let's start from the anterior side. So this is the skin. We have the fat layers, the muscle layers, then we have tendons. Now we have here one important structure for the protection, and we discussed this in the previous slide, which is the pubic symphysis. Now posterior to the pubic symphysis, we're going to have the bladder. Now below the bladder or inferior to the bladder, we have a special structure that's only found in males, which is the prostate, which is an organ we're going to discuss in this lecture. It's really important. High yield tested in board exams, its pathologies, the structure, so we need to keep it in mind. Posterior to the bladder and prostate, we're going to have the rectum. So that's the normal order of structures within the male pelvis. Now, when we go back to the bladder, we can see one, tiny, let's say, rope or just line that descends. This is going to be the ureter. Now, the ureter is going to join into the bladder through the ureteric internal orifice, which is an opening within the bladder. And then down we have the internal urethral sphincter. Below that, it goes into the prostate, external urethral sphincter, goes into the membranous urethra, and finally spongy urethra, and then it's going to be released from the body. Now, 3 segments of the urethra we discussed through this lecture, but just keep the orientation, the structure in mind. So whenever we go deep and do those structures, we don't, lose focus. Next, obviously, is going to be the female pelvis. Now, the orientation is quite similar with some differences. We can see that the orientation within the pelvis is for a female. The external genitalia is a female external genitalia. The same process. We go to the anterior wall, we have the skin, we have the fat, we have the muscles, the tendons, and then the pubic symphysis. So far, so good. We have the exact same orientation. Now, behind the pubic symphysis is going to be the bladder. Now, unlike males, in males we have the bladder and then the rectum, there's 2 structures in between, which is the uterus and the vagina. Why they are present? They are present here because they are reproductive organs. So that's the main difference between males and females. One more thing to notice is the length of the urethra in females. Now, this is the bladder, as we can see. This is the ureter. It descends all the way down. It goes into the bladder. Now, the length of the urethra is quite, small in females. In males, it's like around 16 to 20 centimeters, while in females, like 4 to 5 centimeters. So this structural difference affects males and females differently in terms of infections, in terms of damage to this area. So just keep in mind that different lengths results in different structures, result in different pathologies in males and females. Now, does anyone have any questions regarding the normal anatomy between males and females? Wonderful. That question, do you get? Yeah, all clear. Thank you, guys. So next is going to be the ureter relations. So as this lecture speaks about the lower, renal tract, we're going to start with the ureter. Now, the ureter extends from the kidney all the way to the bladder. Now, by looking to this image on the left, is this for a male or female, and why? Male. Why? Exactly. Wonderful. So it's for a male. One of the identification point was the prostate, which is special for males. Another was the seminal vesicle. Another identification point is going to be also the vas deferens or the ductus deferens. So all of those structures identify that this, or signify, sorry, that this structure is for a male. Now, the other image is also the same, but it's from a posterior view, where you're going to see that we have the prostate, we have the seminal vesicle, vas deferens, and this is going to be the ureter. Now, the other image is for a female. Now, let me just click. Now, in males, to discuss, we have the ureter, and the ureter is going to be crossed superiorly by the ductus deferens or the vas deferens. Both pronunciation is correct. So that's the ureter. It descends and it enters into the bladder. Now, this is going to be the vas deferens that carries the semen during the ejaculation. So it passes superior to the ureter. So that's the ureter and that's the vas deferens. And next is going to be in females. Now, in females, it's quite important, the orientation of the ureter. Now, this is the ureter, the yellow structure that descends all the way down. Now, as it goes into the bladder, this is the bladder, the red structure, muscle structure. It descends all the way down and enters into the bladder. Now, something passes above the ureter, superior to the ureter, anterior and superior, which is going to be the uterine artery. Now, clinical importance of the uterine artery is that it can be damaged. Now, the uterine artery supplies the uterus by blood supply, to be clear. So during a surgery or the removal of the uterus, probably the surgeon will ligate, will cut the uterine artery. So by mistake, he would injure the ureter or damage the ureter. So the process that results in the removal of the uterus is called hysterectomy. And during this surgery, the surgeon would, by mistake, damage the ureter. So this is a high yield tested info. You would expect such a question in the exam, that which of the following structure would be injured during hysterectomy? And the answer simply would be uterine. Or they would give you a scenario of a surgeon who conducted hysterectomy for a patient, and then the patient had issues with urination, or there was a complication. Which of the following could be a complication? Damage to the ureter. So you should expect such a question. Now for this image here, the orientation is quite difficult, but this is a superior view where this is going to be the bladder, this is the uterus, and this is the ureter. So you can see that the ureter goes all the way to the bladder, and this is the uterine artery. But just keep in mind that in females, the ureter is crossed anteriorly and superiorly by the uterine artery, and in males, the ureter is crossed superiorly by the vas deferens. So a great mnemonic not to forget is water under the bridge. So the water is going to be the ureter, which is under the bridge. The bridge is going to be the uterine artery. So water under the bridge. Trust me, just memorize this mnemonic, and whenever you come across this concept, easily you will remember it. So next is going to be the blood supply of the ureter. Now, I don't want you to memorize all of those stuff. Just make it as a logical stuff. So we all know the pathway of the ureter. It starts all the way from the kidney and descends and enters into the bladder. So think of this. Whenever the ureter is moving and passing all the way to reach to the bladder, it needs blood supply. So it's going to take blood supply from the nearest source. So when it's around the kidney, the source is going to be the renal artery. When it starts descending close to the abdominal aorta, the source is going to be the abdominal aorta. When it comes close to the gonadal artery or testicular artery, the blood supply will be the gonadal or testicular artery. When it goes down into the pelvis, the source is going to be the inferior vesical artery, which is a branch of the internal iliac artery. So make it more of a logical process. Whenever the structure, whether for the ureter or any other structure that comes across you in anatomy, always the blood supply will be close to the structural organ. So in this situation, whenever the ureter descends, the closest blood origin or supply will be there. So for the sake of completion, blood supply for the ureter is going to be the abdominal aorta, will be the renal artery, the gonadal or testicular artery, finally, inferior vesical artery in the pelvis. Now for the drainage, it's quite simple, is the corresponding veins. So it's going to be the corresponding for abdominal aorta is going to be the IVC, the inferior vena cava. For the renal artery, renal vein. Gonadal artery, gonadal vein. Inferior vesical artery, inferior vesical vein. Or it could be also the prostatic venous plexus. We discussed the prostatic venous plexus in the upcoming slides. So, does anyone have any questions so far? Am I going fast or the pace is fine? Wonderful. So, the ureter constrictions. So, what are the constrictions that we can, oh, before that, how many constrictions do we have in the ureter? 3. What are they? Pelviureteric, which is the first one. Pelviureteric, which is this one. As it leaves, this is the renal pelvis, and this is the ureter. So the junction here is called, which is called the uretero-pelvic junction, is the first constriction. Second is going to be the pelvic brim. As it goes above the pelvis or crosses into the pelvis, it's called the pelvic brim. So that's the second one. What about the third one? The wall of the bladder. So wonderful answers. So the first one is going to be the uretero-pelvic junction. This is 1. 2, the pelvic inlet. 3, the uterovesical junction, which is the uretero-vesical junction. Now the vesical, which is usually represents the bladder. So whenever we see vesical, it's called the bladder. It's another way to say the bladder. So think of this whenever it leaves the kidney, firstly, and then whenever it crosses over or into the pelvis, the true pelvis, which is sometimes they call it above the iliac vessels, and finally when it enters into the bladder. Those are the 3 constrictions. So what's the importance of them clinically? Why do we care about them? Why do we care if the patient is or let's say about those anatomical constrictions? Because of calculus. Wonderful. Which is the renal colic, which is renal stone, basic word. We sometimes call it nephrophthisis. So we care that sometimes the patient would have kidney stone, and those kidney stone can be easily lodged or trapped in those constrictions. So that's why we care about them. So constriction importance, renal colic stock. Next, who knows what this represents? Like the big name, the big family name. What type of pain is it? Okay, that's loin to groin, but which is pain, type of pain. Now, the big family name, let's say, or the broader name, we call it referred pain, which is a pain, a structure within the body is damaged or affected, but you won't feel the pain within the body, rather on the surface. So this is called the loin to groin pain. This is the loin, and this is the groin. So loin to groin. That's why it makes sense. Now, what's meant by referred pain? And this is something that we need to clarify to make sure. Pain is a pain-felt application is different from where the actual problem is. So now the loin to groin pain appears why? Because there's inflammation of the kidney, kidney stone, whether it's within the kidney or in the ureter. So the pain will be reflected on the skin. The pattern it follows is the loin to groin pain. Why do we care about this? Which is a sign patients would complain of. The patient would come to the clinic, approach the clinic complaining of sometimes they call it the flank pain. They would point back. They would say, I have a pain that goes all the way from my back down to my thigh. So they describe the loin to groin pain. So it's really important in a clinical setting to know the pattern of the pain. Now, the referred pain name you wonderfully mentioned, which is the loin to groin pain. One more thing to mention is that think of this as a pathway. So if you're going to imagine the kidney with the ureter, you can closely see that the kidney is somewhere around here, and then the bladder is here, and then the ureter passes all the way from the kidney to the bladder. So it's more of a logical pathway where the pain follows. So does anyone know what modality is this? Is it X-ray, CT scan, MRI? Radiograph. Wonderful. Is it with contrast or without contrast, and why? Contrast is the color. We want to give the patient something, whether we inject him with the contrast, the dye, or without. Wonderful. With, because we can see the calluses. Now, I would agree, but the main reason why it's with contrast, mainly because we can see the colored structures. We can see the structure are emitting light. So this indicates that this is with contrast. One of the structures is the calluses. We can see here the minor calluses, the major calluses, the renal pelvis, and the ureter. So this is going to be radiography with contrast. It helps visualize structures. So which structures? We mentioned them, the minor calluses, the major calluses, the renal pelvis, and the ureter. So whenever there's a renal stone or kidney stone that blocks the pathway, the color or dye or this whitish color will be blocked. So if there was a kidney stone that is at the pelvic inlet, let's say, so we're going to see that the dye ends here. So there is a whitish color here, and then beyond that point will be black or dark. So this indicates that there is a kidney stone or a blockage at that specific point. Finally, okay, this is a pyelograph. Pyelo, we mean the kidney. So there's two ways to inject the dye, whether intravenous, which is giving an injection to the patient, or retrograde. Retrograde is that we inject the dye from the external urethral orifice. So from let's say the urine outlet from the body, the dye would be injected, and then it's going to be moving retrograde, backward, all the way to the kidneys. So there's two methods or ways to inject the patient with the contrast. Next, this is a really good image that visualizes both things, the constrictions and the X-ray. So you can see here we have the minor calluses, the major calluses, the ureter, and the ureter and the bladder is not visible here. The borders would be all visible of the bladder. So that's the pathway after injecting the patient with contrast. Here it shows the constrictions of the bladder, of the ureter. Clearly, this is the first one, the uretero-pelvic junction, the pelvic rim or the pelvic inlet, and finally is going to be at the wall of the bladder. Next, moving to the bladder. Now, this is a quite simple, let's say, anatomy image that helps visualize what's happening here. So this is the pelvic and the pelvis, let's say, and the bladder is a pelvic organ. So it's found within the true pelvis. It's above and posterior to the pubic symphysis. Pubic symphysis. So in this case, this is the bladder, and it can be empty and full. Now, why does this signify that we have multiple ways to palpate the bladder? Now, the bladder could be or would be palpated when it's empty and full. Now, how to differentiate between those two? We'll discuss this furthermore, but just know that the bladder lies behind the bladder. It could be easily palpated. There's different methods to palpate, but for now, just orient yourself that the bladder is a pelvic organ. It's above the pubic and posterior to the pubic symphysis, and finally easily palpated. With different methods, we'll discuss them. Furthermore, just orient yourself with the ureter as it passes all the way down and enters into the bladder. Now, finally, to end with this slide, we have here a structure that appears as a triangle. Does anyone know what's its name? The triangle. So this structure, what's the significance of this structure? Why do we care about it? What does it function in, let's say? Senses fullness, exactly. So it can send signals. One of the ways that it sends signals to the body that we need to micturate or urinate. So we'll discuss furthermore. It's important and related to different procedures. But for now, just make sure that you know that it's related to the sensing of the fullness of the bladder. Next, this is a superior view of the bladder, as you can see. This is the bladder. This is the rectum. We have here the intestine. We have here some arteries that are passing here and there. Now, what does number one signifies? It goes into a structure that's exactly at the middle. It's the median. It's the medial umbilical ligament. Exactly, it's the medial umbilical ligament. What about two? This is the bladder, but what muscle can we see here? What's the name of this muscle? The dorsal muscle, exactly. Now, is it skeletal muscle or smooth muscle or cardiac muscle? And why? Involuntary, exactly. So this muscle, this is a smooth muscle, and it's going to be involuntary muscle. It helps in the emptying of the bladder. So this is okay. أنا قاعد أكبس أحيانا وأوريكم الإجابة. So what is a possible congenital defect in part one? One is the medial umbilical ligament. Now, in the utero and fetus, this is going to be patent, which is open. And sometimes the patient will be born, and this is going to be still patent. You're going to have more about this in the embryology lectures. But basically, the newborn would be born with a patent urachus. Now, basically, because the fetus would urinate this pathway in the utero, and now when he's born, it should be converted into a ligament. But some patients will have a patent urachus. You should intervene fast to prevent any complication and close this, let's say, pathway or shunt. Function of number two, we mentioned that it's going to be responsible of the emptying of the bladder. It contracts, so the bladder is going to be emptied. Next, moving on, structure one, which is going to be the seminal vesicle. You mentioned previously this structure wonderfully. It's a part of the male reproductive system. It has specific secretions during the reproductive process. Two is going to be what? We've mentioned this also. It's part of the male reproductive system. The vas deferens, exactly. So some people would overlap the ureter with the vas deferens. Now, a good way to differentiate is that the ureter won't go closely to the seminal vesicle. However, the vas deferens or the ductus deferens would go closely and fuses with the seminal vesicle. So you can see closely and clearly that this is the seminal vesicle, and the one that's above it is going to be the vas deferens. While the ureter is quite a bit, let's say, far from both of those two structures. Moving down to the female reproductive structure, what does 3 represent? It's a part of the uterus. The cervix, yeah, which is the opening or the head of the uterus. Now, what about number 4? Exactly, it's the vagina, the anterior wall, sorry, the posterior wall of the vagina. And this one's going to be the anterior wall. Now, why do we care about it? Because it's closely related to the bladder. No, manage. No, this is the anterior wall of the vagina. So this is anterior and this is posterior. So does anyone have any questions regarding the male and female, let's say, anatomy? Because it's really important in the clinical segment. Amazing. ممتاز. طيب. What do we call this case? A patient, a female patient presents in the clinic after birth, complaining of urine incontinence, cystocele. Wonderful. So, cystocele. But what's cystocele? When a patient says that, when we say that the patient is having cystocele, is that there is a prolapse of the bladder. Sometimes it's called herniation, which is a protrusion of the bladder. We can all agree that this is not a normal appearance of a bladder. The bladder should be, elevated above. The vagina should be patent. We can see that the bladder is going and invading into the region of the vagina. So this is not a normal appearance of a bladder. No. Is it seen more commonly in males or females? In females, because the bladder is more close to the inferior wall, or we call it the urogenital diaphragm, which is something going to take up in the next semester. But just keep in mind that the urogenital diaphragm is more importantly related to the stabilizing of the structures within the pelvis, and any damage to it would affect the continuity of those structures. Now, what can cause it? Not pregnancy, pregnancy indirectly, the childbirth, exactly. Whenever we have the patient, when a patient giving birth, because of the increased pressure in that area, damage, exactly. Wonderful, guys. Wonderful that you know what's the levator and eye muscle. It's a muscle going to take later on in the next semester. But for now, just keep in mind that the cystocele is more common in females. It's seen during childbirth because of increased pressure. It would result in the damage of the levator and eye muscle. So the pelvic floor would be damaged and there's no continuity. So some clinical presentation, the patient will have loss of urine, protrusion of the urinary bladder. So they would include those two stuff in the clinical scenario. A female, would be a question. A female gave birth 2 days ago, and now she's presenting with loss of urine, protrusion of the bladder. What do you suspect? You suspect cystocele. Next is going to be more discussion about the bladder. Now, something that you need to identify, which is going to be the neck of the bladder. So basically, the neck of the bladder lies posterior or behind the pubic symphysis, around 1 cent or 1 inch beyond, and the rest is going to be within the prostate gland. So think of this as this is the apex of the bladder, this is the body of the bladder, and this is the neck of the bladder, the narrow place. So this is the neck behind the pubic symphysis and continues with the prostate. So this is the neck of the bladder. Next is going to be identifying the neck of the bladder for females. Now it's more easily to identify. The same concept, the same way. This is the pubic symphysis. Posterior to the pubic symphysis, 1 to 2 centimeters. This is the neck of the bladder. Now, of course, it's short because the urethra is short in females. Now, going to our lovely boy and guy, trigon. Now, you guys mentioned trigon and wonderfully related that it sends the fullness. So whenever there's fullness, it sends signals, sensory fibers that we need to micturate. Now, it's a trigon. So we have 3 angles. What are those angles? Or 3 sides, let's say. Okay, 2 ureteric orifice. What about the third one? And 1 internal urethral orifice. So we have 2 ureteric orifice. So we know that we have 2 ureters, and those 2 ureters should open into the bladder. So they open in those 2 points. We have here the right ureteric orifice and the left ureteric orifice. Now, finally, the third angle is going to be the internal urethral orifice. So collectively, those 3 will result in a trigon. Now, something that you need to keep in mind is that let's say the surface of the trigon is different from the different parts of the bladder. So you can see here that the bladder here is more of increased surface area. It's not flat, while in the trigon, it stays flat. So whenever it's going to be stretched, or feels fullness, it's going to send signals that we need to micturate. Now, important in which procedure? What intervention that we could do? Cystoscopy. Why? What can happen during cystoscopy? You would trigger the trigon. So the cystoscope would go approach the trigon, and as it goes over the trigon or touches the trigon, would trigger it and would result in micturition immediately during the cystoscope. So I guess you all know what's this. This is the cystoscope. It's a procedure done. Why it's important? Why do we do cystoscope? Why do we do cystoscopy? Look at the bladder. So we investigate for any tumors, for any injuries, kidney stones. Wonderful answer. So the importance of cystoscopy that we investigate, sometimes we suspect ulcers in the bladder, kidney stones, tumors, most importantly. So it's a modality of investigation. Next is the blood supply. So the blood supply of the bladder is quite simple and quite similar in males and females with one exception. So a general rule, let's say both, let's suspect that both blood supply in both males and females is the same. So the arterial supply in males first is going to be the superior supply, which is the superior vesical artery, which is a branch of the umbilical artery. 1. 2 is going to be the inferior supply. The inferior supply is going to be the inferior vesical artery, which is a branch of the internal iliac artery. So far, so good. Next, the venous drainage. The venous drain is not going to be the corresponding arteries. It's more of it's going to be the internal iliac veins. This is 1. 2, we have the prostatic venous plexus. Now, whenever we say a plexus, it's an accumulation of veins around the structure, and they're highly connected. So it's a highly vascular area. So keep in mind, prostatic venous plexus and internal iliac veins are responsible of the drainage of what? Of the blood supply of blood from the bladder. Now, the one exception is that in females, they don't have the inferior vesical artery. It's replaced by what? Does anyone know what replaces the inferior vesical artery in females? It does not replace, but it has a different naming. Yeah, the vaginal artery. So in females, the inferior supply of the bladder is going to be the vaginal artery. Next. Watch this. We're going to have a quick run over investigations and procedures. What's the name of this procedure? Where does it lie? This is the pubic symphysis. It's exactly what's another name for it? There's another name for this. Suprapubic. It's going to be the suprapubic aspiration or the suprapubic cystomy. Your answer is also correct, which is the paracentesis. But like this one is going to be the suprapubic aspiration. Now, when you say we aspirate, like we take out some fluids. So it's a procedure where we can't. Let me ask you this question. What's the purpose of doing such a procedure? Why do we do such a procedure? Painful for the patient. We go suprapubically, insert a needle, and then take urine out. Why? Okay, what things can the patient have? Why can the patient pass urine through the urethra? Obstruction. Jamil, do you know any condition where the patient would have obstructed urethra, especially in males? Something related to the prostate. Old age men would experience this. You know this, which is the benign prostatic hyperplasia. In a patient with benign prostatic hyperplasia, there is a enlargement of the prostate, so the patient won't be able to pass urine. So sometimes we need to aspirate urine, but mainly this one procedure is used in terms of someone who's having infection, and at the same time, there is no pathway, the pathway of the urethra, whether it's obstructed or destructed as a result of trauma. So some indication BPH, which is the benign prostatic hyperplasia. You have the urethral blockage damage and UTI, which is the urinary tract infections. Next is going to be the prostate and the urethra. Moving on, where's the urethra? Oh, sorry, where is the prostate? Yep, it's this structure, the one pointed by the arrow. So it's a pea size, it's small, it's really important, carries a lot of value, carries a lot of functions, a lot of fluids passes through this small structure. That's why it's really important, and it's highly discussed and highly tested on. So what's the name of this organ? The prostate gland. What's special about the prostate gland? What are some stuff special that we care about the prostate gland? Now, something that's really important about the prostate gland is that there's a pathway for urine. So urine path through this. So this is the segment that we discuss later, which is the prostatic urethra. This is one. Two ejaculatory ducts open into it. Three, there's a prostatic duct that opens into the prostate pathway because there's prostatic glands. So prostatic glands secrete secretions. They go through the prostatic duct and then they open into the prostatic urethra, into this pathway. So there are three fluids that pass through the prostatic urethra within the prostate. One is going to be the urine. Two is going to be the ejaculatory fluid, the semen and the sperms. Three is going to be the prostatic secretions that are going to be secreted through the prostatic glands. Next. So what's the name of this urethral part, which is the prostatic urethra? Where does the prostate or the prostatic ducts open? Once more again, into the prostatic urethra, there's around 12 to 20 ducts into it. Now, the question, what type of muscles are the sphincters? Now, we have two sphincters here. We have the internal urethral sphincter and the external urethral sphincter. What type of muscle is the internal urethral sphincter? Is it skeletal muscle or smooth muscle? Internal is a smooth muscle. What about the external?
Recording in progress.
The external is also smooth or skeletal? Okay, you mentioned, okay, I just noticed you said also external is skeletal. So the difference is that the internal is involuntary control, so it's smooth muscle. The external urethral sphincter is a voluntary control. So this muscle we usually control whenever we need to micturate and we need to postpone the micturation for a bit of time, couple of minutes. So this muscle prevents micturation. So it's a voluntary control skeletal muscle. Right, next, this is the prostate. And it clearly shows that there's different segments and we call them lobes. So what are the lobes of the prostate? There are three, they're shown here. But what? Name them, please. Middle, anterior, and posterior. Wonderful. So this is the medial lobe, this is the posterior lobe, and this is the anterior lobe. So where does the medial lobe lies? Now, to make this question more clear, what two structures or two pathways, are borders of the medial lobe? This one and this one. So what do we call this pathway? This is the prostatic urethra, yes. What about this one? What do we call this pathway? Ejaculatory duct. Wonderful. So the medial lobe is bordered anteriorly by the prostatic urethra and inferiorly by the ejaculatory duct. So we discussed the lobes. What about the zones? Now, what are the important zones that we're going to discuss? The transitional zone, the peripheral zone, and the central zone. Now, the question is that you need to link them with each other. So you know that we have zones and lobes, but which lobe is related to which zone? So a question, the transitional zone is related to which lobe? The medial lobe. What about the central zone? The central zone, is it the median or anterior? Median. What about the peripheral zone? related to which lobe? Posterior, P for P. So just make sure that when you link zones with lobes, never include the anterior lobe. So it's always the transitional zone with the medial lobe, and so it's always the transitional zone with the medial lobe, the central zone with the medial lobe, and finally the peripheral zone with the posterior lobe. So P for P. So it's a good way to remember. Now, why do we care about the division of the prostate? Why not we just call this is the prostate and move on? Why do we care about the division of it? Diseases, yes. That's why we care about pathologies. So some diseases are more specific or more prominent, let's say, in specific zones and lobes rather than others. So by knowing in which zone or lobe we have the disease, we can suspect what type of disease the patient is having. Now, this is a patient who presents to you with a pain, unknown pain, or let's say blood in the urine that's been for a while, which is called hematuria. He's old age, he's above 60. He's a smoker. And then this patient, we did for him a digital rectal examination. And then we saw that the posterior lobe is enlarged and appears, let's say, ridged as a rock or as a wall. What do we suspect the disease? Cancer, prostate cancer. Exactly. So which lobe is commonly affected? You wonderfully correlated that this is going to be the posterior lobe. If the doctor asks about the zone, you would say the peripheral zone. So this is a really good way to memorize PPP. So the first P is the prostate cancer, the second one is the posterior lobe, and the last P is going to be the peripheral zone. So this is a high yield question that would easily come in the exam. So please don't miss the grade on this on such a question. So what examination is done for the patient to examine the prostate? Physical examination. Digital rectal examination. Exactly. It helps in examining the prostate. But what about the two sides it metastasizes to? So metastasis, it means that it spreads to. So if there was a tumor in the prostate, what are the two sides? Wonderful. One of them is the brain. It spreads to the brain. The other side is the most common one. The vertebra. Exactly. Do you know why it spreads to the vertebra? The venous plexus. Yes, if you recall, we mentioned at the beginning of this lecture, we have the prostatic venous plexus, and it's a highly vascular area. So whenever there's tumor, it can be easily, let's say, delivered or spreading easily through the blood. And also, in the vertebra, there's the vertebral venous plexus. So you have two sides with highly blood supply. So tumor can be easily spread or metastasized to one of those places, whether the brain or the vertebra, which is the most common site. Next, this is a patient which is a 55 years old, or let's say 60 years old, with a long-term decreased urine, let's say, rate. There is urine incontinence, which is sometimes he's not able to pass urine. There is hesitancy. There is a decreased flow of urine. So what do you suspect? And when we did the digital rectal examination, we found that the prostate is enlarged, BPH, which is the benign prostatic hyperplasia. Now, another name for it, which is the prostate adenoma, which is, I doubt they ask you about this, but just keep in mind that two names for it: prostate adenoma, and the most common name, which is the benign prostatic hyperplasia. Now, benign because they suspect that this is a tumor, but it does not spread, so it's benign. Prostatic or prostate because it's in the prostate. And then hyperplasia, which is increased cellularity. So that's why it enlarged. Let me just read this question. No, in the OSPE or SEQ, it's more, to be on the safe side, just write the whole name: the benign prostatic hyperplasia. You don't know what happened. No need to write both of them, prostate adenoma or benign prostatic hyperplasia. But whenever you know that this patient is having prostatic benign hyperplasia, write the full name. Don't just write the abbreviation to guarantee the mark, because sometimes they would not give you the full grade for just writing the abbreviation. Sometimes you would misspell even the abbreviation. So make sure to write the full name to guarantee the grade. So which lobe plus zones are commonly affected in this patient? We said that the patient is having prostatic, the median lobe. What about the zone? The transitional zone. Now, to make the concept of this pathology clear, when we look into the transitional zone, it like wraps around or hugs the prostatic urethra. So whenever it involves this region, there's hypercellularity, hyperplasia, increased cells. So there's enlargement of this prostate. It's gonna enter into the prostatic urethra. So it results in narrowing of this prostatic urethra. At the end of the day, results in blockage or occlusion of this prostatic urethra. That's why those patients in old age, they experience difficulty urinating, decreased urine frequency, sometimes hesitancy. They can't pass urine at the end of the day. So that's why you need to keep this in mind. Now, something the doctor, I guess, mentioned in the recording or transcription I saw somewhere is that they would include in the case that the patient is having a better symptoms at night. Now, just keep in mind if it says that the patient at night is able to pass urine easily or the symptoms improve, they signify that this patient is having prostatic benign hyperplasia. Just keep this in the back of the mind. I doubt they ask you about, but if they ask, you know the knowledge. Now, may complain that the patient will complain that they can't pass urine, difficulty passing urine, sometimes pain while urinating. Other symptoms, the patient will have nocturia, dysuria, and urgency. Now, in those terminology I mentioned in the slides, when the patient says that they have nocturia, which is urinating at night, dysuria is pain while urination, and urgency is they have the urgency to urinate immediately. So keep those three terminology in mind. Nocturia, which is urination at night, dysuria is pain while urination, and finally, urgency is the urgency to urinate. No. Does anyone have any questions regarding the prostate cancer and the BPH? Because they're high yield concepts and they would easily test you on. If you have any questions during this session, please ask about those two diseases because we're gonna keep, they're gonna keep asking you about them in medical school, whether now or later. Now, we spoke about the prostate. So sometimes we need to remove the prostate for some patients. So what do we call the surgery? I know, guys, it's the prostatectomy. Not to waste your time typing. So it's the prostatectomy. So which is whenever you see ectomy, ECTOMY, which is removal of an organ. So this is the prostate. So we have the removal of the prostate. Now we have three ways to remove. The first one, which is shown here, which is above the pubic. We enter, we do an incision, and then we remove the prostate. So this is called suprapubic. This is the first one. Second one, this region, we're going to take in the next semester upcoming blocks, which is called the perineal region, the perineum. So we call it the perineal prostatectomy. The third one is going to be through the urethra. So it's called the transurethral resection of the prostate. So three ways, whether suprapubic above the pubic, perineal region, and finally is going to be the transurethral resection of the prostate. What nerve can be injured? Important nerve that can be injured. The cavernosus. Yes, the the pelvic splanchnic nerve and the cavernous nerve. Now, those nerves, if they're damaged, they would result in defective erection. So the patient won't be able to have a full erection, or what we call the erectile dysfunction, they call it. So moving on to the urethra, which is the longest part of the segment, I guess, or the shortest, I don't recall, صراحة. But this is the urethra. Keep in mind that the urethra in males is more complicated than females, and they would ask you more on it. Like the urethra in females is quite simple. In males, it's around like 16 to 20 centimeters, around those two numbers. This is one. Two, it's divided into three segments, and this is the golden number. In urethra, you have three segments, you have three constrictions, you have three dilations. The three segments. The first segment is going to be the prostatic urethra. This is the first one. Second is the membranous urethra, which is the shortest one of them all. And finally, the spongy urethra, which is the longest one of them. Right. First of all, this is the first segment of the urethra. We call it what? The prostatic urethra. Anyone knows things special about the prostatic urethra? We mentioned some of them previously. if anyone can recall. The widest, wonderful. What also? What do we have special structures that opens into the prostatic urethra? Yes, we have one of the dilations, the ejaculatory ducts, the two ejaculatory ducts open into it, the prostatic ducts open into it, and we have the uvula within. So this is the uvula. So it's the widest, most dilatable part, spindle shape. Posterior wall contains, we mentioned the opening of the two ejaculatory ducts, the ducts of the prostate, and gland open into the male urethra, which is the prostatic glands. Next is going to be the second segment, which is the shortest, which is the membranous. Now, what's so special about the membranous urethra? The narrowest one. So when it's narrow, what do we think of? External sphincter is there, could be obstructed easily by something else. When we have a procedure and we insert a device, during catheterization, yeah, it does not. No, we're not scared about it getting stuck. What's more of injuring the area. So it's an area where it comes at a bend and it's narrow. So the physician should be careful that during the insertion of the catheter, the indwelling catheter, he should make sure that he does not injure the membranous urethra because it's narrow and short. So the shortest plus narrow, surrounded by the external urethral sphincter. You mentioned that amazingly. And one last thing, it contains the bulbourethral gland. So this is the bulbourethral gland. It's one of the glands that's related to the reproductive system of the male. You would take this in the intrareproductive block. It helps in the neutralization of the pathway of the urethra. So because sometimes it's acidic because of urine, so it helps in neutralization or making the pathway basic. Next is going to be the last part, the third segment, which is the longest one, which is the spongy part. Now, some special stuff about the spongy part. It's within which structure? What structure contains this? We have three structures within the penis, and then one of them contains the urethra, and two of them contains blood vessels. Like one, it's the longest part. It passes through the corpus spongiosum. So we have three, let's say, I'd like to call them like three towers. So this is the first one, second one, and third one. This is a cross-section of it. So this is the corpus spongiosum, and then it contains the urethra. It helps in keeping the urethra patent. The other two are the corpora cavernosa, which is going to be filled by blood during the erection. So whenever the penis is filled with blood, those structures will be filled with blood. Whereas the corpora spongiosum are going to contain the urethra. That opens into the external urethral orifice, which is the opening of the penis where the urine is going to be removed from the body. Now, also it contains the ducts of the bulbourethral gland. Now, this is a question that they would ask you of. Now, we have two questions that appears. Where does the bulbourethral gland located, in which segment of the urethra? And the second one is, where does the bulbourethral gland ducts open? Now, when they ask about the gland itself, the answer would be the membranous urethra. When they ask about the ducts, where they open into the spongy urethra. So this is a quite, question that they can twist the words in and fake you in or make a blunder. So just make sure membranous urethra contains the gland itself, the bulbourethral gland, while the ducts opens in the spongy urethra. Also, there's the bulbar fossa and the navicular fossa. Moving on, we have two structures here, which is the sphincters. You guys mentioned this wonderfully. We're not going to waste time on it. If you do have questions asked, we have two. We have the internal urethral sphincter, external urethral sphincter. Internal, you guys mentioned that it's a smooth muscle. It's involuntary. The other one is going to be the external urethral sphincter. It's going to be skeletal muscle. It's voluntary. Keep in mind that the innervation of the internal urethral sphincter is going to be the sympathetic innervation, and that's what dominates during the urination. The sympathetic innervation dominates over the parasympathetic innervation. This is one. Two, okay, my camera was off all the time. I just noticed this thing. So the external urethral sphincter is a skeletal muscle. It's innervated by the pudendal nerve, and it's surrounded by the membranous urethra, as we mentioned previously. Right. Next, this is something, honestly, personally, I think it's low yield, but I don't know why the doctor mentioned, but we need to discuss. Keep it in mind because you can easily test you on. Anything mentioned in the slides is the exam material. So he's just emphasizing or just explaining how do you catheterize patient, which is something going to take in third year and fourth year later on. But just make sure that the patient is supine, is lying on his back on the bed, and then hold the penis at the right angle. And then you need to what do you call it, desanitize the area, to lubricate the catheter to make it easily to enter, and then insert it into the external urethral orifice, which is this one. Insert the lubricated catheter and push it all the way forward. Now, the reason why the doctor mentioned this slide, I guess, to bring the importance of the membranous urethra. So as you proceed by pushing the catheter into the urethra, you're going to pass the sponge urethra and then goes into the membranous urethra. Now, here is the critical area, the critical segment, where you would injure the urethra. So you need to take care while you are catheterizing a patient to make sure that whenever you reach the membranous urethra, to push gently and slowly, not to injure the urethra. So the clinical importance, as we said, what? Membranous urethra is highly susceptible to injury. Why? Because it's narrow and at an angle. And finally, yeah, because it's short also. Right. Next, those are also this is the final slide for the urethra, which is the female urethra. It contains two sphincters, the internal urethral sphincter, this is one, to the external urethral sphincter. We also mentioned that the same way, the same innervation in males and females, the same type of muscle, the internal is smooth and the external is going to be skeletal. Now, female urethra and female, is shorter than in males. What's the significance of this? Keep in mind, if they ask you about this, is that sometimes, or not sometimes, because of the shortness of the urethra in females are more susceptible to have infections, about urinary tract infections more than males, especially because of the closeness between the female urethra and the vagina. So they are more susceptible for urinary tract infections than males. So this is something they would ask you about. Just keep it at the back of your mouth. Now, also, it's embedded in the anterior wall of the vagina. So this is the anterior wall of the vagina, and the urethra is kind of embedded in the anterior wall. Next, let's go to the cross-sectional image. This part needs you guys to be active because it really helps you in the exam, whether in the MCQ segment or the OSPI segment. So to orient you with this image, this is a cross-sectional CT scan, which is colored for you. Now, imagine that you're viewing the patient from the inferior side. So whenever you go down, this is going to be the side of his feet, and whenever you go upward, is going to be his head. Now, the right side here is going to be the left side, and the left side is the right side. So whenever I point to this side, this is left or right? Hi, Jamal, this is right or left? Right, wonderful. So the other side will be technically the left side. So is everything oriented and well? So we can kick into the cross sections. Right. Hello. What's number one? It's a muscle that helps us in breathing, the diaphragm. Mumtaz. But what about number two? It carries blood. The aorta. The aorta. Right. What about number three? So this is the aortic hiatus. Three. The left kidney, yes, it's the left kidney. What about the structure above it? Above the kidney, what do we find? The suprarenal gland or the adrenal gland, both works. Right. And this one is going to be okay above the area. So this is the right adrenal gland. Honestly, it's quite to identify. So sometimes if you don't know what's the structure in the cross section, you can identify, just memorize. So there's two ways, whether you know to identify the structure if you can't. For the sake of the exam, just please memorize so you get the grade. But what about number six? It's the accompany of aorta. It's compared to aorta. Yeah, the IVC, the inferior vena cava. So next, what's the structure? Number one. Isn't it the left kidney? أي. لا صح صحيح. This is the right kidney. So this one is going to be technically the left kidney. طيب, what about number 3? It points to this line. There's a barrier here that surrounds the kidney and the structure within. Is it the fascia or renal capsule? We have two answers. Which one? Is it the fascia or the renal capsule? It's 50-50. It's the renal fascia. ممتاز. So it's the renal fascia. What about number 4? Okay. أنا ما قاعد أضغط زيادة وأطلع. It's the perirenal fat. So number 4 is the perirenal fat. To memorize this is the kidney, and it's surrounded by fat, and the fascia surrounds the fat and the kidney, both of them. So it's as a layer. So they're stacked. You have the renal fascia, the perirenal fat, and then you have the kidney itself. What about structure number 5? لا مو اليوريتر. It's the renal sinus. You could also call it the renal pelvis, بس يعني for the sake of the exam, would doctor just call it the renal sinus? خلاص, to give him the exact question that he'd like. What about 6? This is not an organ. This is a muscle. That's the psoas muscle, yes. طيب. لا, this is the دقيقة. لا, wait a minute. كان في سامر ماشي في الدقيقة. What's this structure? It's pointing, it goes out from a vessel, and then it supplies. This is the renal arteries, yes. What about 7? طيب, it's the renal veins, and they accompany the renal arteries. Next is going to be 1. What's number 1? Lumbar vertebra. حلو. Try guys to mention in the ECQ or the OSP the complete answer. So don't say just vertebra. Say lumbar vertebra or sacral vertebra. So this one is the lumbar vertebra because it's the lumbar region. Right. What about 2? This is the muscle. This is the psoas muscle. What about 3? This is from the posterior wall lecture. Posterior abdominal wall. ممتاز. It's the quadratus. It's the quadratus lumborum. What about number 4? It's the aorta. 5. ما بحس عيب أسألكم, أنتوا عارفين which is the IBC. You guys know the structure. But given the mind, because sometimes when you skip them in the exam, you discover that you've been overwhelmed by them, but then you're gonna kind of forget the orientation of them, which one is the aorta, which one is the IBC. So keep practicing on them. 5. Moving on. What's this structure? It's a bony structure. Iliac crest. What about 2? It's a derivative of iliac. وش نسميها؟ iliacus. So this is the iliacus muscle. What about 3? And number 3 we masters in this muscle خلاص. The psoas muscle. طيب. What about 4? 4 صراحة ما أدري, they're asking you. It's a part of the colon, yeah, large intestine. So this is going to be the ascending colon. Now صراحة I doubt they ask you about it. بس نرجع ونعيد. The same point is that keep those points in your mind. No, we don't know what they're going to ask. They can't ask anything in the content. But mainly it's going to be highly covered in the GI block. What about 5? If you had the ascending colon, then yes, we should have the descending colon. Finally, what about 6? The stomach, it's not the stomach. The stomach is above, is way more above. Small intestine, it's the loop of the small intestine. Yes, correct. Let me just fix my media. Is the voice clear, guys? Because I guess my headphones died. Is the voice clear? Yeah, ممتاز. طيب. Next خلنا نبدأ. What's structure 1? It's a bone structure. The femur, the head of the femur, exactly. What about 2? The bladder. It's the bladder. What about 3? 3 طبعا this structure هنا. هذا. Something that's posterior, related to the GI tract. It's the rectum. ممتاز. What about 4? 4. Between the rectum and the bladder, we have structures. هم في 3 options. أي واحدة منهم. Is it vas deferens, seminal vesicle ولا ureter؟ نشوف. It's the ureter. So this one is the ureter. صراحة it's quite difficult to orient, but this is the ureter. This is the left ureter. This is the right ureter. If you can see this one. But then what about 5? يلا 2 more options. Is it seminal vesicle ولا vas deferens؟ vas deferens. It's the vas deferens. ممتاز. طيب. Next. This structure 1. This is the bladder. ممتاز. What about 2? rectum. ممتاز. What about 3? خلاص عاد هو third option. Yeah, this is the seminal vesicle. What about 4? هذا 4 دقيقة. This is 4. 4 vas deferens. vas deferens صح. صراحة نسيت that's why I waited for to see the answer. طيب. 1 is the pubic symphysis. 2 it's a male organ or main structure. لا مو vas deferens ولا rectum. اللي وراه rectum صح اللي بالأخضر. بس it's a male specific structure. It's the prostate. هذه prostate. 2 is the prostate. What about 3? الأرو it points to a opening. وش دي الأوبننج؟ opening within the prostate. وش نسميها؟ the urethra, the prostatic urethra. لا, it's the prostatic urethra. The internal urethral orifice is a bit above, but this one is going to be the prostatic urethra because it's within the urethra. It's encapsulated within the urethra, let's say, or surrounded by the urethra. طيب. 4 is rectum, you answered previously. طيب. Now let's go to this. It's a bone structure. One more again. Same location. The femur. Hip bone or femur. طيب 2. This is for a female. This is a female pelvis. This is the uterus. طيب. A question out of context. Does anyone know what are those 2 structures? They have the same name. Yes, this is the fallopian tube. طيب. لا دقيقة. This is the round ligament of the uterus. The fallopian tube a bit above. Hello. The round ligament of the uterus where it contains the uterine artery. So this is the round ligament of the uterus. What about 4? 4 شوي صعب 4 الصدق يعني. 4 is the loop of the ileum. صراحة I doubt they ask بعد, but for the sake of completion, memorize it, know it in case they got it in the exam. 5 is the rectum. You've got this multiple times, correct? This is a question. This is a male or female pelvis? Female. Yep. This is the uterus. تمام. So structure 1 is the hip bone. 2 is going to be the femur. 3 is the today's topic. bladder ممتاز. 4 is the identification point اللي helped you knowing that this is a female, it's the uterus. وfinally 5 rectum. خلاص you're mastering the CT scan, the cross sections. فإن شاء الله you're fine with any question. What about 6 finally? The ureter. Okay, استغربت uterus على طول. Okay, ureters ممتاز. So okay, I thought that was the last one. خلاص توقع this the last one ولا upcoming one. One is what's the structure? This is a difficult question or challenging one ترى. This is the structure. Yep, this is the urethra. What about this one? The one that's posterior to it. Posterior to the urethra. What structure is posterior to the urethra in females? لا. The vaginal wall, this is specifically the vagina. So posterior is going to be the anterior vaginal wall, vagina, but then posterior vaginal wall. So collectively, this structure is the vagina. Third one, at you master, this is the rectum. This one, I don't know, they gave you only one, let's say, CT scan, uncolored, there's like 11 structure to mention. So this is a high yield صراحة image that you need to master and try to know the structure and memorize at the same time. So what's one? This is one of the, yeah, this is the liver. ممتاز. What about two? The spleen. ممتاز. Three? The left kidney. ممتاز. صح. What about four? The renal sinus, the left renal sinus to be more specific. You would say renal pelvis بس ما ادري اذا بيحسبونها صح ولا لا. I don't know if they're gonna mention take this as a correct answer. So to be on the safe side, just mention the left renal sinus. How do we know what? If it's the hilum or لا. So this is a really good question. The hilum is where, like you know the concept of hilum, where arteries and veins enters into. So we have hilum in the kidney, we have hilum in the lungs. Now the hilum is going to be at the entrance. It's not at the center inside. So probably there is an identification point. For here, as he puts it into the center of the kidney, it's where the urine accumulates. So this is the renal sinus or the renal pelvis. Now if it's going more to the sides of the arteries and veins, and the ureter, where they leave collectively, we call that area hilum. But here is not pointing to the arteries or veins, no, only to the sinus. So hilum, it's for the veins, arteries, and the, you got the, okay, ممتاز. Just to make this clear, when they ask about the hilum will include the artery, the vein, and the ureter in the case of the kidney. Well, here the sinus is only the pelvis area where the urine accumulates initially. The same thing for the liver, if you recall from the CV block. The hilum is going to be the artery, the arteries, the veins, and the bronchioles, the primary bronchiole or the main bronchi. So this area is called the hilum. Right. 5 is the same thing, the renal collecting system. Now, why this differs from that one? Here where things get complicated in CT scan. صراحة, to be honest, this is a difficult thing to identify. So the easy way to go in the final is to know the differences between them. So this one is going to be the renal sinus and this one is going to be the renal collecting system. What's 6? The two friends, which one is aorta and which one is the IVC? Aorta? طب why not IVC? وليش aorta? It's on the left. ممتاز. This is a good way to remember, is that you know which side is the aorta and which side is the IVC. So this one is going to be technically the IVC. What about 8? You can trace these structures. The renal vein, the left or right one? The left renal vein. طيب. What about 9? صراحة اللي يعرفه ترى فنان. So the one who gets this question correct ترى, it's a difficult question. ممتاز. The superior mesenteric artery. So it's a high yield concept. Especially you're gonna have a question, the slide later on this session, where there is a syndrome that occurs for the patient when the superior mesenteric artery passes above or around, let's say, the left renal vein and then the aorta, so it compresses it. It's the nutcracker syndrome. So 9 is the superior mesenteric artery. 10 is going to be, well, it's shown here, which is the transverse colon. I think that's all for this. Yeah, that's all for this slide. Please know this slide by heart because they would ask you about this in the MCQ, maybe SQ or OSPI. They would just put this and then number one of those structure and name the structure. So to be on the safe, just memorize. If you couldn't understand it, just memorize. So this slide is one of the slides that I do hate as a student, honestly, when they speak about the supply, the nerve supply and those stuff. The only way to go around is to memorize. So for such, you need to know that the supply of the pelvis is the anterior iliac artery. The parasympathetic innervation is the sacral parasympathetic S2 to S4. So honestly, you need to sit down and memorize this slide by heart because they can easily get questions. And I think they don't get questions, commonly. But keep in mind that this slide, the only way to go around is to memorize. Right. Sympathetic nerves, and I guess you covered this in physiology more often, but just to keep in mind, the kidney is really important in terms of regulation of the blood pressure. So you would go maybe furthermore, maybe in this block or upcoming years, that the importance of kidney in terms of regulation of blood pressure to control the blood pressure, to control blood pressure. Now, you've been across a system which is called the AAS, which is the RAS, the renin-angiotensin-aldosterone system, which is mainly related to the kidneys. This is one way. Another way is the sympathetic function of the kidney. It results in the control of the blood flow to the kidney by reducing it or increasing it through the sympathetic nerves. So just keep in mind that the kidney is really an important organ, a vital organ, in terms of controlling blood pressure, whether to the whole organ, to the whole body, or to it specifically. Right. Now this is micturition reflex. Guys, do you had a question? Do you had the lecture about micturition on its own, or no? Like, have you covered it in physiology? Okay, mumtaz. So we could go over this briefly. If anyone have a question, we can go into depth. So we covered previously the two sphincters, the internal urethral sphincter and the external urethral sphincter. Now the internal one, we mentioned it's involuntary, it's smooth muscle. So when micturition occurs, it's going to be relaxed through the body, you have no control over it. If you would like to terminate micturition or prevent it from starting, you would control the external urethral sphincter, which is this one, structure 3. The past session, honestly, I included this link here, which is, I guess, enough for last year. I don't know if your lecture, so maybe they added something more or less, but for the process itself, it's more than enough. But sometimes the doctor adds some clinical stuff, some stuff which is important for him, so he would ask you about this. So make sure that you cover the lecture, but for the reflex itself, it's more than enough. You can view this link. But this link takes you to the PAL session. تمام. So I don't know, guys, do you want me to go over it or no? Because I feel like you're saying just move on. But let's go over it for the sake of completion briefly. So we have a process that facilitates emptying and a process that inhibits emptying. So to facilitate emptying, you have the pelvic splanchnic nerve, which is a parasympathetic fiber. So it facilitates emptying. So it stimulates what? The detrusor muscle. So we mentioned what's the detrusor muscle? It's a smooth muscle within the lining of the bladder that contracts, and this helps and aids in the micturition process. Now we have also somatic fibers, which is controlled by the pudendal nerve. Now to inhibit emptying, you have sympathetic fibers sent by what? By the sacral splanchnic nerve. Now it's mentioned in this lecture brief because it's an anatomy lecture, and physiology lecture you're gonna have the details there by that specific PAL, or you can see the PAL of last year. Right. Next, okay, okay, there should be, appear on click animation. So basically, this is a kidney stone, and we've mentioned it previously at the beginning of this lecture. Now, another way to say kidney stone, to say renal colic. A more complicated way to say kidney stone is the nephrocoliasis. So nephrocoliasis is kidney stone or renal colic. Now, kidney stone is basically crystal aggregations of molecules that aggregate and form a solid structure
that over time progresses and blocks the urethra. And in severe cases, it results in let's say, a blockage of the urethra, blood, urine and blood, no, blood and urine, to be more specific, urine and blood, and those complications. So most common types, you have two types. The most common is going to be the calcium oxalate and then calcium phosphate. Now just memorize them and keep them in mind that whenever you see calcium oxalate, which is the most common type of kidney stones. Second is going to be the calcium phosphate. Other there's complications. Complications is mainly the obstruction of the urethra. You have something, if it appears in a question in the exam, don't freak out, which is hematuria. If they bring you that the patient is having hematuria, it means that the patient is having blood in urine. So when there's blood in urine, you would think of kidney stone. It's not the only cause, but one of the causes is going to be kidney stone. Now, how to diagnose? A good way to diagnose is CT scan. There's multiple ways. A lot of guidelines, you would use ultrasound, but for the sake of this lecture, keep in mind that you use CT scan to diagnose renal stones and also cysts. Now, do you guys know what's a cyst? Yes? What is a cyst? It's just swelling. A swelling, a swelling that contains fluid. So whenever there's a fluid within a structure or a layered structure, it's considered as a cyst. Now, we're going to go over back to the same concept, which is constrictions. Now we have three constrictions. I'm really glad that you guys, I'm pretty sure also that you know what are those two sections by now, constrictions, but there is another way to mention them. And that's the reason why we bring this up, because sometimes they have different namings for those constrictions, but they lead for the same, constriction. So they also call it the renal pelvis. This is the first constriction, which is the uretropelvic junction. They call it the renal pelvis constriction. Another one is the pelvic brim, which is the inlet of the pelvic. They call it pelvic brim. Third one is the bladder inlet. You would also call it the uretrovesical junction or the bladder inlet. Three of them are correct, are completely fine, but just know them in case they bring them in different terminologies. They're the same thing. Next, clinical importance we mentioned, renal stone would be lodged, would result in hydronephrosis. Now, hydronephrosis is mentioned in slides, that's why it's popping here. Basically, hydronephrosis, you have atrophy of the kidney. Now, what do we mean by atrophy? Shrinking of the kidney. The size of the kidney is going to be reduced. So this is hydronephrosis. Why? Because of the backup of urine. So the ureter is blocked, so urine can't be passed, so it goes back to the kidney. When it goes back to the kidney, it results in hydronephrosis. Hydronephrosis is renal atrophy. Atrophy is shrinking in the size of the kidney. Or atrophy in general means that there's a shrinking in a specific organ. Type of pain. What's the type of pain? We've mentioned previously. The referred pain. What do we call it? Yeah, what's the pain? From what to what? Loin to groin. So this is loin to groin, is this type of pain. Sometimes they consider it as a flank pain, which is the pain at the loin. Back here they call it the flank pain. So this is a case of a patient who experienced let's say, bagworms or a bag of worms in the left scrotum. And he's a male patient. What do we call this syndrome? Where the left renal vein is going to be compressed. The nutcracker syndrome. Exactly. So we call it the destroyer. I call it the destroyer. Honestly, they don't call it. It's my own terminology. You can just ignore. So the destroyer. So what's the diagnosis? Going to be nutcracker syndrome. Another way to memorize, you just name it by what's happening. It's the left renal compression, left renal vein compression. The renal vein is going to be compressed. So if you look at this image, normally what's happening is that this is the left renal vein and it crosses over the aorta below the superior mesenteric artery and goes into the IVC. Now, because it's trapped in a small area between the aorta and the superior mesenteric artery, sometimes it can be compressed. So when it's compressed, the blood won't be able to pass. So it's going to back up into the kidney and it would affect one more structure in males. What is that structure? left testes will be affected. Why? Why the left testes? Why not also the right one? Okay, it makes sense, but why the left testes? The structure that's being compressed is going to be the left renal vein. Why the left testis is involved? Exactly. Because the gonadal vein drains to the renal vein. Exactly. If you look here, we have a vein that goes into the left renal vein. This vein comes all the way from the left gonadal vein. Another name is the left testicular vein. Both terminology is correct, with the gonadal or testicular vein, or you could also call it in a female ovarian. So left ovarian, left testicular, left gonadal. In a male situation, you would call it left gonadal vein or left testicular vein. Both of them are correct. They're purely correct. So, because there's a compression and a backup of fluid, or let's say blood, within the left renal vein into the kidneys, also it's going to affect the left renal vein. So, symptoms, the patient will have left flank pain, and we call the flank pain, which is the loin pain at the side of the kidney. And two, they would have hematuria. Now, what's hematuria? It's going to be blood in urine. طيب. Next, you've mentioned greatly what's happening, but what's the name of this case? It starts with a V, as a hint. Varicocele. طب what's varicocele? Have you taken varicocele ولا لا? Have they explained to you in the lectures ولا they just mentioned varicocele as a complication of nutcracker syndrome? طيب, varicocele basically is let's say a pathology that happens in males only, where there is a backup of venous blood in the plexus within the testes. Now, why this is important? Because it's a medical emergency. Such incidents should be cured fast. They could describe this in a scenario where they would tell you that a male patient, let's say 25 years old male patient, presents to the clinic with a flank pain. This is one. Also, they present with a bag of worms in their left scrotum. Left scrotum, which is the bag of the testes. So the left scrotum, they're having a bag of worms, they explain it. So this is varicocele. You would immediately say that it's varicocele, and then the patient is having left flank pain. So this is immediately nutcracker syndrome, and this is an easy question to get. So this is something that the doctor mentioned in the slide. I don't know he mentioned, but for the sake of completion, we're gonna mention and read. Yes, that's the emergency. The reason why the testes are placed outside of the body or away from the body is for temperature, away from the core temperature. You're going to take later on that you need to have a 3-degree temperature difference in the testes to have a production of sperms. So in the case of a patient who's having varicocele, the temperature increases there because of the blood there is a lot. You're going to know the mechanism there, but basically a patient with varicocele would have infertility if there's no intervention done immediately or as soon as possible. So yeah, this is a great addition. Thank you for adding that. Such a question. It's such a note. So the doctor mentioned something here is that renal vein entrapment syndrome differs from the superior mesenteric artery syndrome, in which the third part of the duodenum is compressed in the same angle. Now, what's the relevance in this block? Honestly, I don't know. But just keep it in mind because he would ask, because it's an exam material at the end of the day. طيب. This is a patient presents with a left flank pain. Sorry, right flank pain. Patient presents with right flank pain. What do we call this? And he had a lower urinary tract infection previously. Perinephric abscess. Amazing. So this is the perinephric abscess, which is presents as a flank pain. What can be the causes of it? Why does a patient would have a perinephric abscess? Inflammation could be a cause. So we'd have infection, inflammation, and also TB, tuberculosis. All of those could go. But inflammation is included in both of them, in tuberculosis and urinary tract infections. So let's say it's a result of infection and a result of tuberculosis. Right. What are the two types? Now the patient would present. Now to make this more clear, you have a perinephric abscess. حلوين. And then it would have two presentation or three presentations: perinephric abscess and then just flank pain, or perinephric abscess with a one more presentation and third one also shoulder pain. Wow, that's a deep question. So this is quite true, but it's less common. So what's mentioned in the slides to stick it for the exam is that the pain could be ascending. So the perinephric abscess would ascend a bit, and then when it ascends, it triggers the phrenic nerve, and triggering the phrenic nerve would trigger the diaphragm, and then the pain would reach the shoulder eventually. But basically, for the sake of the lecture, it would ascend and affect the diaphragm, so it triggers the phrenic nerve. This is the first one. Second one is the opposite way, where it descends. So behind the psoas major, it affects the hip joint. So the patient would present with a perinephric abscess, so flank pain, and then with hip pain, hip joint, it affects the hip joint, so there's a hip pain, or all the way around above, shoulder pain, or there's an issue with the diaphragm, irritation of the diaphragm and the phrenic nerve. طيب. This is a quite complicated صراحة slide, but this is a patient, old age, presenting with a urine in the blood. He's a smoker for like 20 years. He's old age, as we mentioned. Male. What's this case is about? He's a heavy smoker. It's yes, tumor, cancer. So this is the renal cell carcinoma. It's the renal cell carcinoma, which is the renal clear cell carcinoma. This is the most common type of tumor in kidneys. Now, where does it arise? From which part of the kidney? Is it from the cortex or the medulla? From the renal cortex, exactly. Like, what symptoms can the patient present with? What some symptoms the patient? Hematuria, exactly. The patient will have hematuria, which is blood in urine, and also would accompanied by mass in the abdomen. Now, it depends on the size of the tumor. Sometimes you would be able to palpate to feel the mass in the abdomen, and sometimes you won't be able, depending on the stage of the cancer and the length. طيب. Where does it metastasize to? So when you say metastasize, it spreads. Where does this tumor spreads to? Think of it as the venous drainage. Think of the pathway when we have the kidney, and then it goes from to the left renal vein, and then to the IVC, and then to the right atrium, and then to the lungs. So a common place that the renal cell carcinoma metastasizes to is the lungs. So this is a common complication. They would have a case for you in the exam where a patient have a abdominal mass or presenting with blood in urine, which is hematuria. Would also have a mass in the abdomen or complications in the lung. All of those lets you think that the patient would have renal cell carcinoma. طيب. Next case is for a patient, female. تمام. She lost like 11 kilos in the last 2 months, and she complains that whenever she stands, she feels pain, lower back pain. Nephroptosis. What's nephroptosis? Now, a good way to remember diseases is that to know the terminology. When you say nephroptosis, exactly, it's the kidney dropping. Nephro, it resembles the kidney. Ptosis is that dropping or falling down. So the kidney is falling down from its position. Now, this is a good something that you mentioned, that is the fat depletion, because fat depletion. Now, and that's why I mentioned in the case or scenario that a female, and then she lost like 11 kilograms in 2 months. So this signifies that there's a significant loss of fat, and that results in the drop of the kidney. Why does the kidney drop? We know that the fat, plays a major role in stabilizing the kidney, but why the kidney is not stabilized in its place? And your answer is correct, because yes, exactly, that's the exact question, a precise question. It's correct that you say that the kidney drops because of fat, but moreover, the renal fascia covers the kidney anteriorly, posteriorly, but it does not cover it inferiorly. So whenever there is this massive and significant loss of fat, The kidney will drop, especially when the patient stands. So keep this in mind when you have a question or a scenario of a female who loses significant weight in a short period of time, and then whenever she stands, this is really important. Whenever she stands, she experiences pain, lower back pain or complications. So immediately think of nephroptosis, which is the dropping of the kidney. طيب. Next, خلينا نشوف. We've covered how to correct nephroptosis. This is also advanced, knowledge included, but for the sake of completion, we should include it in the slides. How do we correct? It's surgically, but with what we call the surgery. Nephropexy, exactly. Keep it in mind. صراحة ما أدري إذا بيسأل ولا لا. I doubt he asks, but always keep it in mind لأنه it's exam material. So this is nephropexy, which is a surgical procedure where it corrects the place of the kidney into its original place. So fixes the kidney to the posterior abdominal wall. طيب. Next. This one I'm not going to say anything. You should know. صراحة this is a deep question, which is, do they put MCQs in the MCQs the image or just words? صراحة it depends on the doctor. Some doctors prefer to include the clinical scenario with the image that helps you and aids you in the diagnosis or choosing the correct answer, and some do not. But definitely including question would make it easier. And if I was a student and I saw this image, maybe I would think that sometimes this is a tumor, but I would have a differential, which is nephroptosis, especially with the clinical scenario. But it depends on the doctor, honestly. Some doctors prefer including image. Some just have the scenario and find your way. طيب, why? Oh, لا. What's the mnemonic? I gave you a mnemonic at the beginning of this lecture. What was it? From this image, بس. This is a female, and this is a ureter. Water under the bridge. Exactly. This is image. صراحة, it's way more better than the previous one. It shows you exactly what's happening. This is the water, which is the urine, and the bridge is going to be the uterine artery. Like water under the bridge, which is the water is going to be the urine. The bridge is the uterine artery, which supplies the uterus. Which, تيجي وش كان سؤال? In which surgery do we care about the ureter and complication would occur? Damage to the ureter, ligation of the ureter by accident. Exactly, the removal of the uterus, which is the hysterectomy. طيب. Ureter lies posterior and inferior to the uterine artery. You can flip this, which says that the uterine artery is superior and anterior to the ureter. So you can do it both ways. طب. Which ligament the uterine artery lies in? This information was mentioned in the cross-section segment. What's the name of the ligament? It starts with C. No, not the cervical. This is a clever guess, but it's not the cervical. Not the round. It's the I guess it's round. It has two names, صح? No, it's the cardinal ligament, which is the transverse cervical ligament. No, yeah, cervical is also correct. And I mixed up between the round and the cardinal. No, it's the cervical transverse ligament or the cardinal ligament. But round ligament is something else. I have a question for you guys. Have you took the ligaments of the uterus and those orientations? Well, لا. Okay, makes sense. This is going to be covered in the indelible block next semester. But it's good to have knowledge about them now. This is really good to have the cardinal ligament, the transverse ligament helps you in orientation of the anatomy. طيب. This slide is full of words, but it's pretty simple. حرفيا pretty simple. But for the sake of completion, it needs to be inclusive. طيب. Urinary bladder, we've mentioned previously in this session, it's easily be palpated. But depending on gender, depending on age, depending on the amount of fluid within the bladder, the palpation process differs. وش معناتها? It means that how to palpate the bladder. 1. Full adult's bladder. Whenever the bladder is full and in adults, you're easily palpating it by placing your hands above the pubic symphysis. So suprapubically, you can easily palpate the bladder. طيب. What about empty bladder in males? Now, empty bladders in males, you would also place your fingers above the pubic and palpate, but this is not enough. If you recall the digital rectal examination, you would do the same thing, but rather than palpating the prostate, you're going to go ascend more and palpate the bladder. So this is for males. Now for females, also the same process. You're going to keep a hand suprapubically above the pubic symphysis to palpate. However, you're not going to palpate through the rectum, you're going to palpate also through the vagina. So in males or females, adults, you need to palpate from two sides. In males, suprapubically and also through the rectum. Now in females, you're going to palpate also suprapubically and through the vagina. Now those cases, if the bladder is empty. If it's full in adults, you can easily palpate only suprapubically. طيب. Next, it's going to be in children. In children, regardless if it's empty, full, you can easily palpate suprapubically because of the anatomical and the small area that's there. I know it's a kind of a boring slide, but just get the concept. 5 ways to palpate, well, four ways to palpate. Pretty simple, pretty easy. They can easily test you on. Right. What's this examination called? We've mentioned it repetitively this time, or this session. DRE, the digital rectal examination. طيب. What structure is being examined? This is a kind of recap, final slides عشان to finalize this lecture. This is the prostate. ممتاز. Which lobe is being examined? Which zone? Peripheral zone. ممتاز. What differential do we have in mind so we do this examination? Differential is that what we suspect the patient is having as a disease. Prostate cancer, exactly. طيب. So this is an advanced question صراحة, but it's mentioned in the slide. What blood test can we ask for to assess for the size, let's say, or the health of the prostate in terms of size and growth? Wonderful, at least you got 2 letters of that. It's insane at this level. So it's the PSA, which is the prostate specific antigen. Exactly what you said. So it's a test. It's one of the gifts that we can use, that we can assess the health of an organ, especially if we suspect tumor, with a blood test rather than invasive test. So the PSA, if you have a question about the patient who is having benign prostatic hyperplasia and you need to assess his case, or you have a patient with prostate cancer and you need to assess his case, you'd go for the PSA, the prostate specific antigen. But malignancies, where does it spread most commonly? I'm asking about the prostate cancer. I said it does not fit the context. To the brain and vertebra. So vertebra is one of the most common places to spread to. طيب, this is a question أتوقع إنه we answered, but for the sake of completion again, why it spreads to the vertebra? Most commonly to the vertebra. Enough plexuses. Yes, we have 2 venous plexuses, the prostate venous plexus and the vertebral venous plexus, and they're highly, a high amount of blood there. So, and highly vascular, that's a specific word. So whenever you have high vascular supply there, wonderful, connected. This is also a good word to mention, صراحة. I mentioned both of them are highly vascular and connected. For whenever there's tumor infection, they would easily spread from one side to another, specifically tumors. They call it the hematological spread. When it spreads through blood, they refer to as a hematological spread. طيب, last slide عشان خليكم خلاص ترتاحون. What do you suspect? A large prostate gland in a patient. What's the pathology here? BPH. You can include in the scenario, it's an old age patient. The patient's having issue with urination, is having pain while urination. Sometimes he can't control or stop urination. It's like spontaneous. So this is BPH, the prostatic benign hyperplasia. Diagnosis, prostatic benign hyperplasia. Which lobe is affected? Plus in depth. So which lobe? ممتاز. Medial lobe. What about zone? Transitional zone. This is an easy guaranteed MCQ question. I do guarantee you have a question about the zones and lobes for prostate cancer or BPH. So don't miss the opportunity to secure this grade. طيب, you have also enlargement of the uvula. Now, I guess in this lecture we did not emphasize the what's uvula exactly. It's a structure, it's a prominence on the posterior wall of the urethra of exactly the prostatic urethra. So if the prostatic urethra, the posterior wall contains a prominence or an elevation. This is the uvula. In a case of a prostatic benign hyperplasia, this prominence or elevation will be enlarged. So this makes the case more worse. Like signs of a patient with prostatic benign hyperplasia, they will have obstructive uropathy. I think you're now guys masters in this. They have increased frequency. They have urgency, which is the urgency to urinate. They have difficulty in emptying. So suddenly the flow stops for urination. And that conducts our session for today. Thank you for making it for today. Anyone having questions?
Thank you, Abdullah. يعطيك العافية أبو خلف ما قصرت.
Thing. Sigmoid thing. There was also something in Dr. Vlad's on the practice question.